Neurologist at the Women's Hospital in Melbourne. And on behalf of our Centre of Research Excellence in Newborn Medicine, I'd like to welcome everyone to the third in our series of Listen, Share and Learn. So for those of you who are not familiar with our series, Listen, Share and Learn is really aimed to bring together everyone involved in the care of newborn infants. So from parents to health professionals to service providers, and really anyone involved in their care, to bring together the different perspectives for a very active discussion with the hope that we all learn from one another by the end of the session. As always, I would like to acknowledge the traditional owners of the land of which I am based at today. So I am based in the land of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to elders past and present, and also extend the respect to all Aboriginal and Torres Strait Islander peoples joining us this evening. I would like to thank, firstly, Dr. Abby Eales, one of our Knowledge Translation Fellows of the CRE, and also Shaza binti Abu Bakar, soon to be Dr. Shaza binti Abu Bakar, who is our research coordinator, both of whom really have been instrumental in bringing together tonight's session. So I'll hand over to Abby now to go through a few housekeeping details with the team. Thank you.
Thanks very much, Jeannie. Welcome, everybody. Tonight will largely be a question and answer session with our panel members, but first we will cover some general information about developmental monitoring and follow-up. We are very grateful to our panelists who have volunteered their expertise and experience tonight. We would like you to note that the panelists are not representing any specific organisation in tonight's discussion. Tonight we have had some questions that have been sent through to us from people when registering, so thank you for that, and we will work through these tonight. But of course, if you have a new question that arises during our discussion, please type it into the Q&A section that you'll find at the bottom of your screen, and we will certainly try and answer as many of these questions as we can. I'd just like you to move, the support services slide. Thanks, Shaza. Our discussions tonight around developmental monitoring and follow-up may actually be quite personal for you and potentially upsetting. And at the end of the session, we will share this contact information again about the resources for support. But before we do get started, you might also find it helpful to think about your own support system should you want to reach out to someone after the discussion tonight. Given this, it's also important to keep in mind that any questions that you ask or details you may include in your questions are being posted in a live public forum, which is also being recorded. You will note that you can also post questions anonymously as well. I would now like to introduce our wonderful panelists for tonight's discussion. Firstly, Professor Jeannie Chong is a consultant neonatologist with expertise in neonatal neurology, neuroimaging, and long-term follow-up. Jeannie is our lead of the CRE in newborn medicine and has research expertise in the long-term health and developmental outcomes of both high-risk infants, especially those born preterm. Vanessa McCullum is a very special member of the CRE's Consumer Advisory Group. She is the mother of 2 children who have both required early intervention for their ongoing development. Vanessa is passionate about advocating for families in this space, and we are absolutely thrilled to have her share her story with us. So thank you, Vanessa. And Professor Alicia Spittle is a paediatric physiotherapist and international leader in the early detection of motor impairments and early intervention for infants at high risk of developmental impairments. So thank you very much, panelists. Alicia, I'm going to hand over you firstly to present the importance of developmental monitoring for children born both term and preterm. Thank you, Alicia.
Thanks very much, Abby, and thanks for the CRE for this opportunity to present tonight. And I've only got a couple of slides and just wanted to, I guess, set the background for the discussion for this evening, and very much happy to be directed by our audience around questions. But in terms of the importance of developmental monitoring, if we take the example of cerebral palsy, which is on the next slide, traditionally, there had always been a wait and see approach to cerebral palsy diagnosis. So rather than actually potentially doing developmental assessments and using CP specific assessments early in development, there was this approach of, oh, well, we'll just wait and see how things go along. And then typically, and I'm sorry, I don't think it's going to come up on the slide. I'm not sure, Shazza, if you press the next button with the animation or not. So typically what would happen in the past is the average age of CP diagnosis was 19 months. But if we think about normal or development, I should say, in general, is that if we think about a baby, even before they're in this picture here where we're looking at them on all fours, they start off by rolling, by bringing their hands to their mouth and exploring the environment. They then go from being on all fours to crawling around the environment, and they practice starting to get up from crawling into standing many times, falling over many times. And there's a lot of exploration that happens. And so if we're waiting for 19 months to make that diagnosis, or even thinking about referring to early intervention, we're potentially missing a really important opportunity very early in development to help these children. And what we might be seeing is not only these children need this have a diagnosis, but we're actually potentially limiting their opportunities because we're not giving them the opportunities to explore the environment, to develop their muscles, their bones, but also that there could be potential that we're not helping them with their cognitive development or language development because we're not allowing them those opportunities to explore the environment. So particularly using cerebral palsy as an example, and particularly because it is a motor impairment that involves movement, it is one that we can often, if we use the right assessment tools, pick up much earlier in development. But I think the other important thing is to say, though, is CP is one of many developmental conditions that we might see children being at risk of, and that can be picked up a little bit earlier because it is a motor impairment. But there are other impairments that we might see, such as autism spectrum disorder or ADHD, that do take a lot longer to diagnose, because we need to give children that opportunity to be in development where they're actually have more opportunities for interaction, for their language development. So each developmental condition that we think about has different age ranges that we can start to do that early diagnosis. And that's why follow-up is really important, because we do know for children who were born preterm or term who might have had a difficult start to life, they're going to have different risk factors and potential to have different outcomes. And so we've got standard follow-up that we do using a battery of assessments, which we'll talk about later. Hopefully we can pick up these things earlier. But I do think it's also important to highlight that it's not always easy to make a diagnosis, and sometimes you might have serial follow-up and the doctor might say, well, we've seen these things today, but we need to wait and see because it's not clear what that diagnosis is. And in those situations, it often might be that they're telling you the facts that this is what we can see, but we don't know. And I think it's really important to understand that it does take time to make a diagnosis of a condition, and it often does require follow-up over time to see how things progress over time. And it often isn't just a one-off assessment. And that's why we like to do serial assessments, because we can see how children progress over time. And then if we just go to the next slide as well, and this might seem completely abstract for some of you who haven't seen a neuron before, but if we're looking here at brain plasticity, and hopefully you can see at 36 weeks gestation in that on one side of the slides, is we can start to see our neurons coming together, and the neurons of what forms our brain network. And when we look all the way up to 2 years, we can see that there's lots of neurons growing and connecting. And you might have heard that saying before, that neurons that wire together fire together, and neurons that fire apart wire apart. So we're really trying to make sure in those first 2 years of life that we're helping the brain develop in those right ways. And then after this time, we actually see what we call a lot of synaptic pruning, but when those pathways strengthen. But that first 2 years of life is really important for hoping that we connect the brain in those right ways, which is why it's really important that we do early developmental monitoring so that we can connect children into those right early interventions at the right time. But it's not just those first 2 years. It's also important that we monitor children throughout development, because there is a variation, as I said, in what we can see early in development, depending on what we're looking at. And so things, as I said, such as motor impairments might be a bit easier to pick up earlier in development, and particularly things such as cerebral palsy, whereas more milder motor impairments such as developmental coordination disorder, which involve difficulties with more complex motor tasks such as dressing, doing up your buttons, zips, shoelaces and things, we're not going to be able to tell whether a 2-year-old has problems with those things, because it's not age appropriate to look at those things. And that's why it's really important that we keep looking at, not only this, for me as a physiotherapist, I'm interested in motor development, but if we look at something such as language development, there's obviously going to be different stages of language development, and that we're going to be able to assess them in more detail as a child gets older as well. So that's sort of it from me for the moment to put in context. The only other thing that I want to say before handing over to Abby and just highlighting it for parents, and again, we can discuss this as a panel afterwards, is just being mindful when we do often pick up things early and refer for early intervention. We often will refer to things such as the NDIS, the National Disability Insurance Scheme. And when we make those referrals, we do it in conjunction with parents, and all parents can actually make those referrals themselves. But sometimes we need to write the referrals using language that often, as therapists and as the medical team, will try and use positive language and focus on the strengths of what a child is doing. But when we're making referrals, often just the way the systems are with things such as NDIS, is we have to focus on what the child can't do to try and make sure that they get the supports to help them do that. And I think it's important that we work with families to help them understand the way we're focusing with our language, because I think language can have a very long-lasting effect depending on the words that we choose, and just making sure that we have an understanding with families that what we're focusing on when we might write something as a referral to try and help them get funding for intervention, versus the language that we might use when we're actually giving families feedback or the child feedback, focusing on the positives and the strengths of what they're doing. So I'm happy to discuss that further as we go along as well. But I'll hand back over to you, Abby. Thanks.
Great, thanks, Alicia. And we did have a few questions that came in at registration that I think will be great for you to talk to in the Q&A, such as how you actually enhance a comprehensive learning environment for a child, and also, other than screening and onward referrals, what protective strategies should we prioritise in those first 12 months. But I will remind you of those when we get to the Q&A. And just a little reminder for those on tonight's webinar, please, if you do have questions, pop them in the Q&A, and we will certainly get to those. So thank you, Alicia. I would now love to hand over to Jeannie to provide us a bit of an overview of developmental outcomes and follow-up, really, I think, highlighting why we need to monitor development. Thanks, Jeannie.
Thanks very much, Abby and Alicia, for that very nice introduction to the session. So my remit was to talk a bit about developmental outcomes, and I'd like to start by saying, don't worry, I'm not going to bore everyone with statistics and percentages and rates of various outcomes. I just wanted to highlight a few points about developmental outcomes and why we need to keep those in mind when we're doing follow-up. So I think the area of preterm birth is very fortunate and actually has really forged the way in terms of understanding that outcomes beyond acute care are absolutely critical to ensure that we are able to optimize any infant's development. So as a result of many decades of work, we actually know quite a lot about how babies born preterm are like when they get to infancy, childhood, school age, adolescence, and even young to mid-adulthood. So it's a very exciting time for all of us because we need to draw on that knowledge to really help us hone in when we see these children at follow-up. So of course, developmental outcomes are only one aspect of what we need to look at follow-up. I certainly won't dwell on those other domains, but just to remind us that development is only one aspect. There's growth, there's well-being, there's mental health, feeding, settling, sleeping, all those really important things that do contribute to, you know, the wellness and the quality of life of parents and children. So I'll just like to talk a little bit about some of the main domains that we look at when we talk about developmental outcomes, and a lot of these tend to be very age dependent. So from the 0 to 2 to 3 age, when we refer to developmental outcomes, most of us will think about, you know, the main domains that can be assessed with standard developmental testing. So for instance, cognitive, language, and motor outcomes. We are also able to determine social emotional development, which is very, very important. But those tend to be the major sort of areas that we can assess. Now, of course, there are the major senses like vision and hearing. And as Alicia has alluded to, the assessment and the diagnosis of cerebral palsy, of which we now have specific assessments to make us more certain to be able to confirm the diagnosis at a much earlier age than we previously would have. But when the child gets a little bit older, preschool, school age, we have more sophisticated functions and therefore more sophisticated tests and able to probe a little bit more into the different other domains of development. So apart from cognitive development, the IQ, we can also test academic performance, behavior, attention, executive function, and the list goes on and on. As a role, you know, how are these outcomes for children born preterm across all those outcomes I talked about compared with full term? Well, we know that from our cohort, certainly ones from Australia, and it is mirrored worldwide, that for every aspect that you look at, if a baby is born very preterm or extremely preterm, the risk of having challenges in those different domains are higher. And the risk tends to rise the more immature the baby is. Now, of course, these are group data rather than referring to the individual. So it is important to highlight that when we see individual families, that even though an overall rate may say be X%, it doesn't necessarily mean that their child will be affected or the child has, you know, a 50% chance of being affected, because every child is different, and it's important for us to take into account the individual situations, counsel appropriately, and also support and manage appropriately as well. We come to the very interesting sort of, you know, quandary: why do developmental follow-up? And many of us have had these discussions for a long time, but in my mind, given how much effort and resources and care that has gone into the early days after babies are born preterm, it is our responsibility as health professionals to support families to optimize the child's development. And that's one of the purposes of doing developmental follow-up, is to help families. It's to help families understand the expected developmental milestone that we would expect majority of children to have attained by certain ages. If there are challenges that arise, that's the time for referral and follow-up and intervention. However, if the child is reaching the milestones, it's also a very important point to be able to reassure families that their children are following the trajectory that you would expect are attaining the milestones at the time that you would expect. And I think that in itself is a very important aspect of follow-up, is the reassurance of families. Now, I think one of the criticisms of the current care models that we have is that there is no systematic follow-up protocol or process that we have for our babies born, say, very preterm or extremely preterm. Many who are born extremely preterm will now be offered a developmental assessment at 2 years. But as we all know, a lot happens between discharge from hospital and 2 years of age. So one of the initiatives that our CRE in newborn medicine has been actively pursuing, which we hope to deliver by the start of next year, is a National Health and Medical Research Council endorsed guideline for follow-up care of infants born very preterm. And this has been an effort from a multidisciplinary group, not just health professionals, but also parents and parents of children born very preterm, drawing from most states in Australia and a representative from New Zealand, and also from the different groups, including First Nations representatives, and also representatives from the maternal and child health nurse, allied health professionals, education sector, with the hope of getting a very broad input into this guideline. The guideline will hopefully give a recommendation for best practice and will be able to be used by the various jurisdictions to advocate for best care. This guideline will go up for public consultation in very shortly, and we will certainly advertise that through our CRE website, and I will strongly encourage all of you who are here today and to also to spread it to your networks to please give us feedback for the public consultation, because only then will this guideline meet the majority of needs from a wide group of people. So I might just wrap that up, and I'll be very happy to answer questions during the Q&A session.
Thanks very much, Jeannie, for that terrific overview. I am delighted to now introduce Vanessa McCallum, who is a really important member on our CRE Consumer Advisory Group. Vanessa is going to share her lived experience in this space with us. Thanks, Vanessa.
Thanks, Abby. As was mentioned earlier, I have 2 children who access NDIS, but it's my second Zuni, or Jasmine, as she's known to her doctors and pretty much nobody else, who's my friend. She was born in September 2019 at 26 plus 6 and a 939 gram birth weight. Our NICU stay was reasonably uneventful as far as these things go. She spent 70 days at Royal Women's, growing and establishing her reputation as a feisty and fiercely independent little thing, before being transferred to our local. She got knocked around by that transfer process, and it set us back a little bit. She spent 10 days there in the end. That was really difficult for me as a parent. I thought we were further along, and then it sort of got taken away, and it was really hard to kind of get our head around the new processes and new faces, and everything was different and new again. But looking back, I think that part of our journey was really important, because it allowed us to build relationships with the allied health services that we'd remain in contact with once we got home. specifically the speech therapists who were helping us with feeding, and physios who were still monitoring for CP at that stage. When we got home, she, was cleared of CP over that journey, both with the physios at Frankston and with the kite study that we were a part of. And she stayed in contact with those species and their feeding clinic until around 12 months actual, I think, when she was well established with her solids. She met her key milestones by her corrected age, not exactly convincingly, but she managed to do the bare minimum by the latter end of the window. So that wasn't really sending up flags, but there were little behavioural things that we'd notice and wonder about. So she was never able to self-settle, and in fact needed to be physically restrained to fall asleep. We couldn't sing or read to her at bedtime because it was just, she'd become wired, and it was counterproductive. When we go to the playground, she tipped dangerously forward or backwards on a swing. And yet my seemingly fearless daughter would absolutely panic when she was on unstable ground like sand or a trampoline. She had a tendency to seek out sensory input, almost never did what she was told, no matter how simple or reasonable the request, and her tantrums started quite early. They were frequent, they were often violent, and in a way they were kind of predictable. They were almost always around transitions, and we'd struggle with the same tasks every time they came up. She was always falling over our feet too. She, almost like she wasn't aware of where her extremities were. Still, I mean, these things seem like pretty minor things, and could plausibly have been nothing. I had an incredible maternal health nurse who'd helped us through the early days of our NDIS journey with my first, but this was more subtle and it was more complex because there was some amount of delay that was expected, and her early life had been disrupted by trips back to hospital, and COVID restrictions had meant that she hadn't necessarily got the same kind of socialization as she might have otherwise. So there was this question of, well, maybe she just needs more time and she'll catch up on her own. It wasn't until we were called back by the Royal Women's for our Bailey development testing at 2 years corrected that we finally had something tangible to go on. Her results showed her to be much further behind in all areas than we'd expected. And we were surprised, and I wasn't entirely convinced that the results were 100% accurate, but I did at the same time feel that the assessor had seen a fair demonstration of her abilities on the day that we went in for testing. So, we felt that the results warranted further exploration. Our pediatrician was fairly unconcerned and non-committal about the next steps, but we were sort of familiar with the NDIS process and whatnot, so we decided to go ahead, armed with our allied health history, our Bailey report, and our observations. We were able to reach out and argue that we had delays in multiple areas of development, primarily gross motor and behavioural, although the Bailey did show speech and cognitive as well. They were the sides that I was less convinced with. Ultimately, I was still reasonably unsure whether Zumi needed assistance or not, but I decided to leave that up to the system. I give them all the information that I could, voice my concerns, and let them tell me whether they thought we had a case or not. As was mentioned earlier, the application process can be a bit confronting because it does require you to focus on the negatives and sort of highlight the child's failures, it feels like sometimes. But it can also be a really validating experience. For the first 2 years of Zumi's life, I'd basically tortured myself with questions about, whether parenting's meant to be this hard. Am I just not good at this? Am I catastrophizing and looking for problems that aren't there? Being able to take my observations and give them to somebody who was an expert, was great to be able to put my mind at ease. So Zumi's had an NDIS plan now for just short of 12 months. No diagnosis beyond a global developmental delay, which allows us to access the early intervention. We've been accessing exercise physiology weekly, OT fortnightly. We've dabbled with speech and are considering adding in psych. I can see now what were minor delays last year were unlikely to resolve themselves without the assistance that we've received. And if we hadn't have reached out for help, she'd just be that much further behind her peers now and set to fall further behind as they use that basis that they have to kind of build upon and leap into all those fabulous things that kids are meant to be able to do. I really consider us lucky to have been given the opportunity to access these services, and she does too. She absolutely loves her sessions and her therapists. They've become a really integral part of our support network. And to her, these are just, the activities that she does in her week, as another child might, do Jimbaroo or whatever. The odds say that our prems are likely to need a bit of help here and there to catch up. And I think as parents, we need to acknowledge that and be vigilant. The sooner delays are addressed, the smaller the gap is that needs to be closed. There'll be well-meaning people along the way, both medical and not, who tell you that everything is fine. But we need to trust our gut. We're taught to advocate for our kids in hospital, and that doesn't end when we go home. No one but us sees the whole picture, and sometimes things are grey. And rest on the accumulation of just little observations. So if there's any doubt, I think it's always best to reach out and ask the question. Thanks, Abby.
That was wonderful. Thank you so much, Vanessa, for sharing your story. I know that the panelists have got questions for you, and hopefully the audience have got some as well. And on that note, I'll just ask all the panelists to turn on their cameras, which you have. Thank you. We'd love to do a Q&A session. So the Q&A is open and live. Please post your questions if you have any. But I'll just hand it over to the panel members to see if they've got any questions to start with.
I might start by asking a question, and I'll pose this one to Vanessa. Vanessa, thank you very much for sharing your story. I think sometimes it's really difficult to reflect upon it, and I really laud you for doing it with such clarity. My question to you is, if you could go back to the time when you were discharged from hospital, and now with hindsight, what's the advice that you would give the health professionals, the medical, allied health, the health system in itself? What advice would you give us in terms of what you need and what your child needs, to minimize that level of self-advocacy that you really had to do? How do we make it easier?
Yeah, that's a really good question, Jeannie. I guess, for Zumi, a lot of what we're talking about is grey, and as Alicia was kind of touching on, the things that are not able to be, it's not developmentally appropriate necessarily to be able to see them in those really early times, but there definitely was things we were seeing right from the start, that we just had to wait and see whether they disappeared or remained. I guess, it would be great, from a medical perspective, if those observations could be validated, even if they're not, even if they don't equate to anything at that time. Just that encouragement to keep watching your children, keep taking note of these things, and at some point, it may add up to something, or it may be nothing. And I guess that must be a really difficult line for medical professionals to walk, where you don't want to concern parents unnecessarily, and you want to put their minds at rest, but my experience is, if the parent has a concern, then a medical professional saying, "Oh, it's fine, don't worry about it," doesn't put your mind at rest anyway.
I think that's very good advice. It's the honesty that comes with the assessment, but I guess pitched at a way where it heightens, it affirms your concerns. And what I'm hearing from you is that we probably should move away from trying to reassure all the time, even though there is a niggle of concern. It's probably more important to acknowledge that, but then perhaps, put it in context if it's not diagnostic or it's not pointing towards anything particular at the time. So that's very good advice for us as healthcare providers. So thank you for that. I might pass over to someone else to ask a question now.
I think just following on from that too, I'd be interested in your thoughts too, Vanessa, but I think it's being honest about what we can tell at that age as well. So if you can say, where we're seeing these behaviours now at 6 months, and in most cases it isn't an issue, but it could also, in a small number of children, the outcome is this, and therefore this is why we need to keep an eye on things, but it's going to take us until this time point to be able to tell you more about that. And just to be honest about what we do know in terms of, we don't know what the outcome will be, and we do need to wait and see, but this is why we need to wait and see. This is why we do a lot of our studies and a lot of our follow-up, to say, this is the percentage that will fall into this category, this is a percentage that will fall into that category. And as Jeannie said, that's a group as opposed to an individual, but these are the individual things that we'll try and look at over time, but why it takes us time as well. So it's acknowledging and that concern of the parents, but then putting it into perspective as to what the odds are as well, and when we'll be able to tell you more too. And I think Abby, you were asking me a question before about what can parents do in that time of enriching the environment. And one of the big things, and I'm sure you've heard it too before, Vanessa, and it's true, is that parents and the home environment makes such a big difference. And there's many, I guess, things that we can do that might be considered simple, but are so important. But whilst they seem like they're simple, they actually do take a lot of time and attention to do. And they're those things that are as simple as saying, play with your baby, read to your baby, but it actually, particularly for a baby who doesn't just sit there and read with you like a 10-year-old or a 5-year-old even might, that it's showing families this is what we mean in terms of reading. It might just be you're not necessarily reading out the words on the page. You can make up the story. The baby's not going to care less, but it's about that interaction and that looking and that engaging. And I think that's what's as health professionals, we've got a role in terms of modeling and showing parents examples of what we can do at home. And I know I often find in clinic when we have a session and show families different toys that we have, that it's just showing them that example of these are some things that they might like or they might not like, but how we play and how we use play to interact. And I think sometimes as a pediatric physio, people say, all you do is play with babies all day. And yes, we do, but we use that play in a constructive way to help development. And I think for parents, and particularly because, life is very busy these days for parents, that highlighting that importance of play, but that how to play well, because like anything, you can do stuff all day long, but if it's not in the right way, it might not be so effective. So we're doing a study at the moment where we're looking at supporting parents to play, and we just had feedback from one of our occupational therapists today with a family saying that it was so wonderful to get that advice and how to actually play with my baby, as opposed to just putting them on the play mat and having them just be under the play mat. They're theoretically playing, but it's the type of play that we do that's really important. And I think also for babies who are born preterm or have those extra challenges early on is about how we support that play, because it cannot be quite as easy. And maybe you had the same thing, Vanessa, read to your baby, but they're a bit more difficult with their behavior, so you don't get that immediate feedback. So am I doing something wrong? This is not easy for either of us. And then it gets hard, and it gets hard and harder. And whereas if you can just do some simple things to make it easier and show that beautiful, look at the way she's looking at you, Vanessa, you're the one who's helping. And I'm sure all these things that you've done, but just again, showing families the things that, as you say, using those positive things to show families what they're doing, what their strengths are, but how those small things can make such a difference as well.
Definitely. I think, thinking back to, being a first-time parent versus a second-time parent is very different in terms of the time that you've got available, and then you add the complication of pumping and expressing and washing all the milk bits and all of that. It's a lot for a parent to deal with. And so to have some guidance from someone to say, hey, when you've got a sec, this is what you should do, is great, because that information is out there if you have the time to go searching for it and try different things and work out what works and what doesn't. But that's a bit of a luxury sometimes that we don't have. So no, that sounds wonderful, Alicia.
Just that comment around the information is out there. Alicia, I wondered if you could speak to that for families who are wanting a bit more information. Where are I guess the websites or the places that they can go to seek some of this information?
Yeah, it's a really good question, and you can spend a lot of time Googling and looking for information, but whether it's accurate information is a whole other question. We do have our Centre of Research Excellence in Newborn Medicine website, where we do have some information for parents, and we can send the link out to that website for people after this presentation, but also resources that are often hosted on government sort of websites, or public services or parent support groups. So things such as the Raising Children's Network is a fantastic resource that has a lot of information. And then also parents support groups such as Life's Little Treasures, Miracle Babies. There's a whole range of parent support groups that I think are really important and can provide that support. But I think the important thing is potentially not to Google too much too if you have concerns, because the problem is you might hear a word that someone says, oh, what? And this is what I was saying too before, when we can say it's most likely, in most cases, this is nothing, but in a small number of cases, it can mean this or that. And so, of course, I'm sure the first thing the parent's going to go do is Google what is this or that, and then diagnose it. You diagnose it in your head or looking out for things. So I think it's really important just to ask as well when you see the doctor or the physio or whoever you're seeing. Can you tell me what you think in terms of, do you think that they are showing early signs of having autism or early signs of cerebral palsy, and what is it that you can say that's reassuring, or what can you not tell me because it's too early to tell too? So I think it's good to look online and look at some of those general resources, but if you have problems specific to your child that you really are worrying about and spending a lot of time searching, is making sure that you actually go to the health professional who's got experience working in those areas, who feels confident to give you that information.
May I just interject there, Alicia, and offer up another resource as well, that was more relevant with my first. There is an app called ASD Detect, which is La Trobe University based, I believe, and that sort of covers up to 2 years of age, I think, and looking for the early signs of autism. And that was really fabulous. It had a lot of videos showing you what a typical response might look like and what an atypical response may look like. And that was really invaluable to us. Albeit we don't have a diagnosis, and still flirt with the edges. But just to kind of demonstrate all the same, that's what other people are saying, that's what the medical professionals are seeing, that's what they're looking for. Okay, yeah. And kind of informing the way that we watch our children at home too, so that then we can provide better information in appointments.
Yeah, I think that's really important too. And I sometimes see, so university-based resources should be evidence-based and very good as well. But just following on from the importance of what parents see at home versus when someone comes into the clinic. So if you're worried about a particular movement, for example, or a particular something, everyone's got a smartphone now. So take a photo or take a video when a particular or a behavior that might happen. You can take that video at home and then bring it in when you see your health professional, so that they can actually see what you're talking about, because what one person might mean with a spasm or a tick or a funny movement is completely different to what someone else might mean too. So if you can actually see what someone's talking about, it can really, really help. So I just wanted to remind people too that when we can talk all night, that's not a problem at all. But we're also here to answer your questions as well. So if you do have any questions, just pop them in the Q&A one as opposed to the chat. If you just press on, for those of you who can't see it, there's the more function, there's Q&A, and you can write your questions there, because we'd love to hear from you too.
I might just ask a question that came in at registration, and I'll blend it with another big question that came up in the discussion with members from our bigger consumer advisory group. The question at registration was around time points. You know, when should we be, what are the monitoring points that we should be checking in? And then I guess the other question that we've discussed a lot in our consumer advisory group is around, you know, parents not knowing when to worry, you know, particularly if it's their first child, not knowing what is typical development and when should I start worrying. And we were talking about, you know, what are the red flags that a family should be looking out for. I know it's a very big question, but just wondering if you had any insight into that around what are the best time points to be doing developmental monitoring follow-up, and are there specific red flags that families should be looking out for?
Maybe I can start with the first question. Time points for development. That's a really very important question, and part of the guideline that I referred to that our CRE will be producing will have a recommended time point in a table, and what particular domains of development and other aspects of follow-up care to look for at those time periods. So that's something that we really are finessing at the moment. So rather than stealing the thunder, it's usually, so what for one, it depends on the individual child. If there are concerns in the newborn period that would, you know, where both parents and the health professionals would be concerned that the chances of having developmental challenges are high, then you would see the child more often than you would otherwise. And the other rule of thumb is usually to try and time the follow-up at major milestones where you would expect major attainment of milestones. It's usually about 3 to 4 months in the first year. One of the feedbacks that we've had from some of the working groups so far is parents like to have contact with a health professional, usually about a week to 10 days after they go home, for some continuity of care. And then there are other time points, and I won't preempt what's coming out in the guideline just yet. The 3-month time point is particularly important for several reasons. One, you know, we've given the baby enough time in those first 3 months to have some new tricks, as I often ask the parents, you know, what new tricks have they got, you know, to share with me. Often I get many smiles, and, you know, a whole lot of things have appeared by then. It's really quite an exciting time. But apart from the child actually attaining some very major milestones by 3 months, there are also some very important assessments that are known to be predictive of long-term major conditions like cerebral palsy. So Alicia will know this better than myself, but the general movements assessments, the fidgety general movements assessments at the 3-month mark is a very good time point where, you know, you can get very useful information. So the timing will depend on major milestone attainment, but at the same time, what assessments and specialized assessments are available at the time that gives us most information. So personally, in my clinic, where I see children who do actually have considerable higher risk, for want of a better term, of developmental challenges, I will see them around 3 to 4 monthly in the first year at least. And then depending on how things are going, perhaps spread that out a little bit more in the second year. But watch out for the guideline. It will give more information and give more explanation as to why those time points were chosen. With the second question, when to worry, maybe I'll hand over to Alicia to start, and then I can finish off.
Well, that's a hard one, Jeannie.
That's why it's over to you.
So just clarifying when families should worry.
Yeah, I think that families are looking to health professionals to sort of tell them whether to worry. But if children perhaps are not getting formal follow-up, I think families are wanting a little bit of guidance in terms of, are there certain red flags that, if my child is not doing something or is presenting in a certain way, that I should be reaching out and advocating to get some monitoring.
Yeah, sure. And so I think it depends. There are the Pathways organization, which is an organization in America, actually has some really nice toolkits with different red flags to look at in terms of development. But I think one of the best things that you can do is make sure that you do go to your maternal child health nurse for regular follow-up, and that's part of why we're very fortunate, the number of follow-up visits that we do get with maternal child health nurses. So I would actually use that as your first point of call, and they will ask you about particular concerning things that should help to identify those red flags. If you feel that you've got a concern and you are worried but it's being dismissed, that's where it can be worth asking for that second opinion. And where that second opinion comes from might depend what resources that you have in your community. So if you are having follow-up at the hospital, can you wait to ask to have that follow-up in the hospital, or is it going to see your GP? So I think it depends on what the specific area is that you're concerned about. But do, as that first point of call, I would start with the maternal child health nurse. There are other services that you can access in the community depending on where the concerns are. So as I was saying earlier, for myself, I'm a physiotherapist. So if you're concerned more on some of those things that are more related to movement, then it would make more sense to come and see a physiotherapist. Whereas if you're more concerned about your child's language development, then it would be worth seeing a speech pathologist, for example. So it depends where your concerns are, and you can go directly. You don't need a referral necessarily to go to see someone privately, but it can be costly as well. So it's just keeping those things in mind. So I think, as Vanessa said, I think obviously parents know their child best, and if you do have a gut feeling that something's not right and you don't feel that maybe that person agrees or that you're not getting that thorough assessment, then go and get that thorough assessment from someone else, and making sure that you've got that relationship. And this is where I think from us as a health professionals is making sure that we communicate what we're seeing to families as well. So if they are concerned about something and I'm not concerned about something, is to say why I'm not concerned, but what I will do about that concern. And that I'm not concerned about this because it's actually very common behavior that we see in infants at this age because of blah, blah, blah. But I'm more than happy for you to come back and see me at whatever time point to see if it's still a concern there as well. So there should always be that option. Again, it depends on your service as to whether you can provide that, but you need to give, as a health professional, make sure that you're giving that parent an alternative, well, not an alternative, a plan of action so that they can also address those concerns too. So Jeannie, I don't know.
Yeah, look, I completely agree. One of the things I always tell parents is don't underestimate your gut feeling. Always trust your gut feeling, regardless of whether you are a first-time parent or you're an experienced parent. Because yes, it's a comment I get quite often in the clinic. I don't know what to expect. I don't know if this is normal, whatever normal might be, or whether this is abnormal. So yeah, I think never forget, trust your gut feeling. Many parents have it right. And I think as health professionals, I'm always reminded that, always have to listen to the family's impressions and concerns. And we may have sort of different levels of concern, but through the course of the follow-up and the appointments, most of the time you come to a common ground and you understand where the anxieties have come from. So that's sort of one point I wanted to bring up. In terms of whether development is typical or not, it's also very hard to tell at one time point, because the developmental trajectory is so different between child to child, and you're just seeing them in clinic at one point in time. So one skill that wasn't there week 1, the next day they go home and they attain that skill. And quite often when you see the family the next day, they'll say, oh, we were so worried about X, and the next day after they saw you, they were starting to develop that skill. So I think it really highlights the importance of follow-up, not just one appointment, and having a good relationship with the practitioner, the health professional, and as you walk that journey together, I think that's the best way to determine what is typical and what is not typical for a particular child's development. Abby wanted me to also highlight an important factor for preterm infants when we are looking at development is to actually take into account how early and how immature the babies were born. So if you're born 3 months early, we do have to correct for that prematurity and not expect the babies to be attaining the skill at their chronological age. So what I mean by that is that if you were born at, say, 28 weeks, so that's 12 weeks preterm, when you are 3 months old, it's actually equivalent to just being born. So you just keep adding that. So if you're 6 months old, both parents and practitioners who are seeing the babies, you would expect to correct for that level of prematurity and expect the baby to be at around that 3 months age. The next question I do get when I talk about correcting for prematurity is, how long do you correct for? And the traditional teaching has been, oh, you correct until the age of 2, and then you don't have to do that anymore. And that in itself doesn't make a lot of sense, isn't it? What's so magic about the 2-year time point when suddenly, all the correction goes away? So I think as a rule of thumb, one should correct until at least the child is through school. And in fact, from a research perspective, we actually correct even up to adolescence. It doesn't then disadvantage the particular individual child in that, they're delayed or they're not attaining this skill. One does have to take into the account that they were born early, and therefore, it's not surprising that they will take a little bit more time to attain those skills. So correction at least until school age, if not older, would be the thinking now.
Thanks, Jenny. And just to add on to that, because there's a question in the Q&A about things to think about for school readiness and that transition to school. And I do think correcting is still really important in that transition of, for me, having children born at term. You're still thinking about if they're close to that cutoff age for school entry, do they go then, or do you hold them back? And that's where I think as well, it's really important to consider that corrected age where they are in that timing around the year, as to whether actually it's another very good reason to keep them back, or know that they're ready to go at this time. And then the other thing, I think, in terms of that transition to school and school readiness, and there are some more assessments that get done around that age as well, but again, it's talking to people and talking to the teacher to see how they're going, even taking them to some of the orientation days at school. If you're not sure about whether they're ready to go or not, try some of those transition sessions and see how things are going. But if you do have the ability to access that follow-up through the hospital, if you get the letter in the mail saying would like to see your child at 5 years or 4 years, and you think, oh, do I need to go to that or not? It often is a really good time to go to those assessments. And it was an interesting reflection hearing from you, Vanessa, about going back for that 2-year assessment, and you probably wouldn't have necessarily expected to find that report, but at the same time it wasn't, like, as it's sort of from what you're saying too, it was consistent with how you were feeling, but potentially not what you expected as well. So yeah, I don't know if you want to reflect on that at all too.
Yeah, sure. I guess there was elements that I thought, oh, you know, I expected a bit of gross motor delay, but she showed up in the 8th percentile, and it was like, oh, okay, you know, I thought behind average, sure, but it was more statistically significant than we were expecting. Other areas, you know, speech and things, I honestly felt she was doing really well with, and that wasn't reflected in her results. But you know, I think, you know, I've kept an open mind, and we've sort of, as I said, dabbled with speech and things, but ultimately I think I was right. It was, you know, maybe she wasn't typical in the way that she put her speech together, but it was advanced enough, you know, didn't quite meet the criteria. I can recall, you know, they were looking for yes or no, you know, just do they say yes or no frequently. And so I know she doesn't. And so oh, she'll indicate it, you know, through different words like this, and they sort of went, oh yeah, no. I think that was marked down as a no. And then it was only, you know, not too long after that assessment that we were driving home, and I asked her, you know, would you like a hot cross bun? And she said, that'd be nice, thanks, Mum. I thought, well, yeah, okay, she didn't say yes, but you know, I think she's fine. So yeah, there were elements that yes, I agreed with, others that I thought, well, maybe not, but it was a basis, it was somewhere to work from. And you know, as to when parents should worry, I always think of John Howard in the early 2000s, and the fridge magnets we all got saying, be alert but not alarmed. I'm like, yep, take it all on board, try not to catastrophize, and you know, add things up and come to a conclusion that's far worse than reality. Just try and stay in that kind of observer role, make notes, and yeah, communicate with your medical team and the professionals around you.
Abby, do you have any questions for us?
No, that was all the questions for this evening.
Well, I think time's getting on, and we've been here for over an hour, and I have to confess to everyone, I've just come back from the US this morning, so I'm fading myself. So look, everyone has our context. We'd be more than delighted to answer questions that may come our way. Please just, you know, ping us a message. We will try our very best to answer. But I really like to wrap up this evening's session by firstly thanking both Abby and Shaza for organizing the evening, thanking Vanessa and Alicia for being on the panel together with me, and also for everyone who signed in the evening, realizing that there are so many competing priorities at this time of the day. Just want to wrap up our session, I think we all agree that developmental monitoring and follow-up of children who were sick or preterm in the neonatal nursery is absolutely critical and probably just as important as their acute care. You've heard from Alicia today why it's important. It's important for early detection so that you can refer the children appropriately for intervention that targets whatever challenges that have been identified with monitoring. I've touched a little bit on the increased challenges that preterm children have in many domains of development at the different ages. But once again, a reminder that, general rates do not apply to each individual child, and therefore it's very important to consider your child's development alongside with the health professionals and maternal child health nurses. And finally, last but not least, we heard from Vanessa herself, her own experience of what it was like to take that journey from NICU to discharge to then realizing some of the challenges that they faced as a family, but very admirably has been very successful in advocating for the best care in order to optimize development. So we've all been very fortunate to hear your story, and hopefully we can go back and reflect on our practices to see how we can improve things. And finally, just to remind everyone that our CRE is trying to improve care in this space. And I also see from Deborah Carey that at Champion Centre in New Zealand, they've got a monitoring program and would love to be part of the feedback group. And yes, we'll certainly make sure we send the public consultation out to you, Deborah, and would really welcome your thoughts. But look out for it for the public consultation phase. Certainly look out for the document next year, which we hope to publicize widely. And hopefully that will just be one of many things that our CRE can do to try and improve the long-term health and development of children and their families. So with that, I'd like to thank everyone for joining us tonight. Please give us feedback. Shaza, is there a slide for feedback where they can feedback to us?
Yeah, if people would like to scan the QR code that's currently on your screen, that would be terrific. And I think, Shazza, you were maybe going to post a link for people as well. I promise you it's a 1-minute feedback. And we'd really, really love to hear what you think. We're hoping to run more of these sessions in the future. So your feedback is invaluable. Thank you.
Yes, and also ideas about other topics of interest that you might have. So with that, I'd like to thank everyone again and have a very, very good evening. Thank you very much.